Good day, friends, and a warm welcome to episode 8 in season 2 of 4D, that is detailed discussion and dialogue in diabetes, in Indian diabetes. Now, when we use the word Indian diabetes, what are we comparing this with? Perhaps we need to compare it with global diabetes. And if so, then we need an expert who has been experienced, who has worked not only in India but also at the global level. So please join me today in welcoming one of the senior most diabetologists of the country. We welcome Dr. Leelavathy Kandaswamy. Warm welcome, madam. Thank you, madam, for joining us. Madam is an endocrinologist trained and certified in the UK, an MRCP from Edinburgh, and she has been a consultant at Birmingham, West Midlands NHS in 2021. Now she works in Adyar in Chennai, and she is one of our leading clinicians as well as writers, as well as reviewers and editors. So, warm welcome, madam, once again.
Thank you very much, sir.
We are speaking of Indian diabetes. So, how is Indian diabetes different from global diabetes? You have worked in the UK, which is a multi ethnic group. Did you see differences between people of Indian origin and those from other races?
Uh,
Yes, ma'am.
yeah, there is a lot of differences. But when I was given this topic about the prevalence of diabetes and complications, I was looking at why is this topic important and what is the difference, how to target. In that viewpoint, I've seen in India there is a lot of dissimilarities and variability in the epidemiology prevalence because of multilingual and cultural variation, lifestyle variation, and also in United Kingdom, this is like less common. That is why we have like highly challenging to prevent the diabetes in our country. So in addition to that, in India we have people with diabetes more younger at the age, and also low BMI population also getting type 2 diabetes. So if we start like from the risk factors to the prevention, there are quite a lot of differences among United Kingdom and India, which also I can cover through the presentation as well.
So, ma'am, we have people from across the country, physicians, who look forward to learning from you. It is said that God puts a burden on your shoulders only after looking at the strength of your shoulders. So, is this correct that Indian doctors shoulder more than their fair burden of diabetes management?
Yes, sir. Because we are dealing with population also from low source economic, like low resource setting population. So we need to individualize the treatment according to the population. So how do we make them get engaged with us regarding prevention of diabetes and its complications? So we have to take a lot of burden actually compared to population. Um, so that we feel satisfied and happy, and also the outcome in that target population will be good as well.
Thank you, madam. So, we look forward to learning from you. Your topic is diabetes and cardiovascular disease. We look forward to learning from you about your insights, your experiences. The floor is yours, ma'am.
We'll have a presentation slide. Um, Today, I'm going to talk about an important topic which I have explained. Like, we need to know about the prevalence of diabetes and its complication in India, because, like explained earlier, there are a lot of dissimilarities. Only if we understand about the prevalence, we can target the right population and can give correct management strategies. Coming to the diabetes prevalence globally, 500 million population worldwide living with diabetes, but they are expected to go up by 30% in 2045. And also, diabetes and complication is widespread cause of morbidity, which can also affect the quality of life and can cause early mortality. Nearly 10% of global all-cause mortality in the adult age is attributed to type 2 diabetes. In India, again, the increased prevalence of diabetes and pre-diabetes over the past decades. In 2019, it's been projected that 77 million people with living with diabetes expected to rise to 134 million in 2045. Amongst them, more than 50% of these individuals remain undiagnosed. According to IDF, it's estimated that prevalence of 8.9% among adults. India is the second largest inhabitant with diabetes. In India, there is 1 in 6 people with diabetes living in the India compared to the world. And this picture shows there is a variation of prevalence within the states of India and also pre-diabetes as well as for the diabetes. Coming to the burden of diabetes in India, along with diabetes, the pre-diabetes also increasing from 2019 to 2045, expected to go up by 40.7 million people with pre-diabetes. Similarly, the old age people also affected with diabetes, which is also expected to go up by 27.5 million. Looking at the leading causes of death, as per WHO, non-communicable disease accounted for 74% of deaths globally in 2019, of which diabetes resulted in 1.6 million deaths, thus becoming the ninth leading cause of death. But on the top, it's a cardiovascular disease. If we take the cardiovascular disease, the Indians with diabetes has got 21.4% of people has cardiovascular disease compared to the non-diabetic, whereas the 3 to 4 times increased risk of cardiovascular disease in Indian with diabetes. And this is Madras Diabetes Research Foundation published this study recently. You can see the dissimilarities and found to have Goa being the largest of population with diabetes. And I live in Tamil Nadu as of now, so which is also has got increased prevalence. So in this chart, you can see almost half of diabetic cases are undiagnosed. It has been distributed according to the countries, and India has got more than 50% of the people with undiagnosed diabetes. Almost 90% of the undiagnosed diabetes cases are in low and middle income countries, according to the World Bank country of classification. So our target should be more in the like rural areas and low and middle income countries for the prevention and treatment. So burden of diabetes in India, which means a recent study has shown um, diabetes in the world, Southeast Asia and India was 10.5, 8.8, and 9.6, which is expected to rise by 12.5, 11.5, and 10.9% respectively in 2050. So if you see disease adjust quality of life years, it has gone up fourfold increase with diabetes from 2016. So most non-communicable disease also gone up since 1990, and diabetes have moved from 35th place to 13th place from 1990 to 2016. We mentioned a couple of times the dissimilarity is a more difficult challenge, and also more of the diabetes people are living in the urban compared to the rural area, which this shift is over the last few decades, and prevalence can vary from 2% to 40%. In one of the study, Madhya Pradesh has got a lesser prevalence, and Tamil Nadu has got 40.3% prevalence. So when we say shift in the prevalence of diabetes, we can talk about urban diabetes. I've given the term urban diabetes because there is a six-fold higher prevalence in urban region compared to the rural. Um, this is because the epidemiological transition. There are so many people from rural areas are moving to the urban for the work and education, and the globalization, and also results in alteration in the dietary habits and increased physical inactivity. And there are a lot of fast food shops with processed carbohydrate. Every street has like more than 10 to 12 shops in the busy area, and we are consuming bread, noodles, cornstarch, high calorie drinks, and vegetable fat. All are rich in carbohydrate. And also, when we choose the vegetables, which is really good, this is also like produced for the good production. Pesticides and herbicides are added, This can also sometimes trigger the diabetic circuits and can cause abnormalities. And for the comfort, we are using a lot of transports, and every day in our life, we are using appliances for day-to-day activities, which decreases our physical activity. And managing work-life balance, um, it becomes stressful for managing the time. All these factors can increase the diabetes incidence and prevalence. If we talk about risk factors, there is modifiable and non-modifiable. We cannot do anything about much about non-modifiable, but modifiable, we can address that. We talked about few, and sleep also is important. It's good to get like 6 to 8 hours of sleep, and also to avoid alcohol and smoking is an important factor as well for a risk of diabetes. Complications. This is what we need to know, and awareness about complication to the population is more important. When we say complication of diabetes, we mainly talk about microvascular and macrovascular complications. There is more towards it. Acute complication is there, like diabetic ketoacidosis, hypoglycemia, and foot infection. And there are bidirectional association of diabetes and other comorbidities. Either diabetes remain as a risk factor for other comorbidities, or the other comorbidities can affect or make the control worst, which can affect the quality of life and can increase the risk of complications, which we'll discuss some of them in this presentation as time permits. So we all know about the diabetic ketoacidosis. The main triggers are like missing the insulin doses, or underlying infection can trigger, and poor compliance is another factor for resulting in diabetic ketoacidosis. Hyperglycemia resulting in ketone formation and acidosis in the blood. The main treatment is like intravenous fluids, potassium replacement, IV insulin. So to avoid this happening, appropriate education should be given about taking the insulin correctly. 2 to 5% of mortality rate for diabetic ketoacidosis among diabetes. And another acute complication that can happen is hypoglycemia. So this is greatest threats to achieve tight glycemic control. And there are many studies which have shown that threefold increased risk of hypoglycemia while aiming for glycemic controls. And the main cause is drug like sulfonylureas and insulin. What happens with hypoglycemia? With a fear, the drug compliance will go down, and the glycemic variability can happen, which can affect the cardiovascular risk, and even the increases the mortality. Not only this, it can also directly affect the quality of life, and indirectly with a fear of subsequent hypoglycemia. And the recurrent hypoglycemia lead to also poor quality of life and increases the anxiety, depression, and mood swings. It's important that we teach patients with diabetes about the hypoglycemia management, along with it, how to prevent further attacks by titrating the medication and the insulin doses. And when there is a risk of hypoglycemia, we have to relax the diabetes targets, especially in the elderly people and the risk group. So micro and macrovascular complications are increasing. This is mainly because there is undiagnosed diabetes. Um, um, by the time we diagnose, these complications would have resulted in irreversible. So um, it is important to emphasize the education about screening at the right age, because nowadays the early onset of diabetes can happen even in 20s. Above 40s, definitely we have to screen. In below from 20 onwards, if there is a risk factor, we have to consider screening for diabetes. Diabetic retinopathy is a microvascular complication, the primary cause of new onset blindness in adults. The prevalence is between like 4.8 to 21.7%, and higher prevalence in rural areas. This is because the diagnosis itself like delayed, and when they get diagnosed, self-care is like very less with their knowledge and their economical status. And most of the diabetes retinopathy in rural India, there is 1 in 5 diabetic patients have retinopathy in rural India. Diabetic nephropathy, the prevalence is up to 62.3%. It's variable and it is the foremost cause of the end-stage renal disease in our world. And 20% of patients with diabetes in their lifetime will have an end-stage renal failure. So the high risk is like poor glycemic control, longer duration of diabetes, high blood pressure, hypercholesterol. Were all risk factors for overt nephropathy. So continuously coming to the clinic, seeing a doctor will help them finding this risk factor and able to manage to avoid the complication. Cardiovascular disease and diabetes. So 3 to 4 times higher risk of cardiovascular disease and diabetes. And this is one of the topmost cause of um, causing death. And Asian have, so especially in Asian, the higher risk of cardiovascular disease compared to global level. In 2017, cardiovascular disease was responsible for around 26% of total death and 13.6% of total disability adjusted life years in India. And the DALY's rate is reported to be 1.3 times above the global average. So in India, the burden is increased by higher relative risk burden and an earlier age of onset and high case fatality and higher premature deaths. Diabetic neuropathy, the prevalence is around 10.5 to 14.9%. Again, poor glycemic control, duration of diabetes is significantly associated with diabetes neuropathy. Diabetes and foot is another acute complication can happen with the infection can trigger the diabetic foot, and up to 25% of people with diabetes are prone to develop foot ulcers. And every 30 seconds, we are losing one limb in the world, and it can give devastating complications, consequences on the health, the economy, in the mental health of the patients. It is important that we address and create awareness um, and improve the medical infrastructures and go through the economic limitation to prevent um, acute diabetic feet. Stroke again is common in diabetes and hypertension patient, and it has 2 to 3 fold increased risk of stroke among diabetes. So diabetes is and osteoporosis. So as I said, we talked about the more common things, and these are all like the association which we come to know over the recent few years. In a patient with diabetes, bone fragility is an important complication, and people with diabetes are significantly higher risk of fractures. And bone fragility is a complex and poorly understood mechanism at cellular level due to vascular, inflammatory, and mechanical derangements. And if you take the bone mineral density, it is low in type 1. In type 2, despite the normal and raised bone mineral density, there is a risk of fracture is very high. And the DEXA underestimates the fracture risk in diabetes. So we have to carefully assess the DEXA scan when we are treating the patient. Non-alcoholic fatty liver disease, its prevalence is around 20 to 25%, and this is the leading cause of chronic liver disease. It's a public health problem, and the incidence is increasing parallel to the rise in obesity, diabetes, and metabolic syndrome. So two main factors, insulin resistance and chronic inflammation. Both are key pathways in the pathogenesis of type 2 diabetes, leading to non-alcoholic fatty liver disease and vice versa. The synergistic effect increases the morbidity and mortality. So we need to take additional efforts to prevent type 2 diabetes to combat the rising burden of non-alcoholic fatty liver disease. This is again emerging field, diabetes and cancer. Both are increasing, and we have more emerging evidence that risk of developing a common cancer is increased in people with diabetes. And also 20% of the patients with cancer already have underlying diabetes mellitus. So both these conditions influence each other. The cancer and its treatment impact on glucose control, and diabetes care can deteriorate cancer diagnosis. So there is we don't have much guidelines. So we need to concentrate on the guidance to manage this multi-morbidity problem during cancer, including diabetes, obesity, and nutritional management. Um, Diabetes mellitus and tuberculosis. Again, another one which is exponentially increasing, and approximately 25% of people with diabetes estimated have, tuberculosis estimated to have diabetes, and tuberculosis occurs in 8% of patients with diabetes. So tuberculosis in diabetes may have atypical factors, so this can delay the diagnosis. For example, predominantly lower lobe involvement, which is not common in tuberculosis. And cure rates of tuberculosis in diabetes is bit lower compared to the no, patients without diabetes, 4.2 versus 0.7 percentage. So prompt diagnosis and initiation of anti-tuberculous therapy and achieving the good glycemic control is very much essential to ensure cure and prevention of reactivation of tuberculosis. Okay, this is like we are having a lot of data, and and it is very important that we talk about gestational diabetes during this talk. Gestational diabetes is a medical complication of pregnancy. Maternal risk of uh, developing type 2 diabetes increases in the future. Beyond that, this is lifelong implication. Sorry, that it has elevated cardiovascular risk, which has lifelong implications in their life, and the risk factors that mediates the lifetime cardiovascular risk present even before the pregnancy when GDM is first diagnosed. So when we diagnose gestational diabetes, we know we've got a risk factor for cardiovascular morbidity and mortality. So, in addition to maternal outcome and maternal cardiovascular risk factor, if we look into the offsprings of pregnancy complicated by diabetes, this also increases the risk of cardiometabolic risk in the childhood due to exposure of hyperglycemia to the baby, and it can cause epigenetic changes. So it is very important that we follow both mother and the child following the diagnosis of gestational diabetes. And when we talk about the current insights and emerging trends in early onset type 2 diabetes, so now it is increasing globally, the early onset type 2 diabetes, along with obesity. And excess risk of microvascular complication, adverse cardiovascular outcomes, and earlier death um, is also happening, and higher adverse pregnancy outcome due to early onset type 2 diabetes. So there is a high burden of complication, increased future risk of multimorbidity, and appropriate interventions to reverse these concerning trends should be a priority. So, like answering to the first question asked by Dr. Kalra sir. So, if we look at how distinct we are in India, so looking at the genetic predisposition, so environmental factors like urbanization, decreased physical activity, excess nutrients, like more and more fast foods on the streets, and low intake of dietary fibers compared to more common in India. And when we talk about the Asian phenotype, despite we have a low BMI, we have a high waist circumference, high waist hip ratio, high visceral fat, increased insulin resistance, high prevalence of atherogenic dyslipidemia, early beta cell defect, all increases the risk of diabetes. And when we look at the clinical profile, higher incidence and prevalence in India, and it occurs in the young age, even at the lower BMI, and high prevalence of coronary artery disease. And the and it also we've got like a little bit lower prevalence of peripheral vascular disease and microvascular disease. So the awareness is more important about this so that we can appropriately find the correct population to treat and give the right management strategies. The most important thing for prevention is addressing the risk factors. So, before we talk about the treatment, it is important to prevent mainly by the awareness talks, health promotion, and once we diagnose, the access to healthcare is more important so that we can detect early and give appropriate treatment. With a lot of research, the management strategy also improved a lot. Initially, we were looking at just the blood sugar, and after that, so many parameters have come, like looking at the HbA1c, looking at the complications, looking at the associated factors to improve the quality of life. Though we are doing so much, but the increasing incidence of diabetes, we are not able to match. Still, it's going up. The complication is also going up. So we need high levels of commitments and multi-sectoral actions are needed to reduce the growing burden of diabetes in India. We can also introduce the policies through the government, like national food policies to target the food industries and smaller shops, and health policies like creating awareness and changing behaviors like smoking, alcohol, and using less trans fat and consumption of less junk foods, and creating a lot of amenities so that we can increase the um, physical activity. And health information and communication is more important. And for the low resource setting team, the drugs availability at low cost is very important so that we can have the compliance of medication and easily they can access the healthcare, like transport cost. So many things are happening. So we still have to concentrate on those things to improve the compliance. So in summary, Asian Indian individuals have a high predisposition to type 2 diabetes, which develops at younger age and lower BMI than in Western countries. Asian Indian people with type 2 diabetes tend to have a higher risk of coronary artery disease and possibly a little lower risk of microvascular complications compared to the white individuals. Since 1960, the prevalence of diabetes in India has increased in both the urban and rural areas of the country and has spread to involve individuals from all socioeconomic strata. And management of diabetes, we face a lot of challenges, but the novel interventions using readily available resources and technology promise to revolutionize the care. So, if we do a lot of things, it can be an set example for many countries um, with low income and middle income countries can follow us. And more research, mainly on the epidemiological data, because of the shift in um, healthcare priorities and advanced data on epidemiology will help us to um, improve the diabetes care and we can prioritize the health program according to the regions. Thank you very much.
Thank you, madam, for that very exhaustive talk. And what I realize is we were speaking about the responsibility, the burden on the shoulders of the Indian physician. Actually, when we read the Western literature, we think of complications just like macro and microvascular. But you have opened up such a huge area of work for us. So many complications, so many associations with diabetes.
Yes, sir, because I've joined a couple of years ago and I work with Dr. Usha Sriram in voluntary health service. She is also a senior endocrine consultant. So the one part is when we talk about gestational diabetes, we were very much interested. We saw there is no correct postpartum management plan following the delivery of young women, and because they need a regular follow-up, they are the people who needs addressing cardiovascular factors. They develop diabetes at the young age, and we need to create awareness so that their young children can be followed up because emerging evidence of developing risk factor for diabetes even in the children. And the other things like we have a tuberculosis team where we were thinking about doing like cross-checking diabetes with the tuberculosis management, like making sure the correct investigation for diabetes is happening. Similarly, in when we manage, we also think about tuberculosis because there is increasing prevalence is happening. And osteoporosis, we recently discussed in ISBMR um, that the how the fragility of the bone need more care, and we don't have much diagnostic marker for that. So we may have to consider treating T-score of -2 when
Okay.
there is a diabetes. So there are like if we talk about different associations, we just have to like individualize according to the topics and the population.
Ma'am, like you said, GDM is one opportunity, window of opportunity for prevention. But we
Yeah.
miss that window if we don't follow up in the postpartum phase.
Yes.
Then you have
Yes.
spoken about bone fragility. Can you share your experiences about menopause? Should menopause be viewed as a pathological phase of life, or can we just view it as a window of opportunity for re-energizing ourselves, for ensuring that we are able to follow healthy practices, especially related to
No,
diabetes and metabolic control?
okay. So I think we should consider both. It's not just like uh, with high prevalence of diabetes and during menopause, they faces a lot of complications like vasomotor symptoms, urinary tract infection, because diabetes increases the urinary tract infection, and also the hormone deficiency can cause similar symptoms. Um, so, like with proper experienced team who deals with menopause and diabetes should follow up this patient. And also, we have to take this window of opportunity because they need appropriate screening for bone health, like 10 years after menopause, if there is early menopause, and like surgical menopause or iatrogenic menopause. A lot of people with cancer have ongoing treatment, and because of the removal of his uterus along with ovaries, the early menopause is common. These people needs proper hormone replacement therapy. So they should be in good experienced hands for the good quality of life.
Ma'am, since there are so many now comorbid conditions along with diabetes, that
Yeah.
means that our prescription becomes very long, and then patients get confused also. So, what is the role of fixed dose combinations in management of diabetes?
Fixed dose combination means like you're talking just about the medications for diabetes, or
Diabetes
are we,
or hypertension, diabetes, like maybe let us say sitagliptin dapagliflozin combination.
you mean the combined medication for
Yes,
diabetes?
yes, yeah.
Yeah. So that can like because according to the severity of diabetes, that we are escalating the treatment. So the combined medication is more useful. But what we have to be careful is for every drug, we know the adverse effects. Then it becomes difficult. Then we have to cut off one medicine and change the medicine. For example, with dapagliflozin, risk of urinary tract infections are common. We can warn the patient about it, and when they are in combined doses, they'll just hold both the medicine. So that is the tricky thing, and they have to come back to us. Similarly, like gliptins and pancreatitis. So in the combined dose preparation, this is the only thing that I found. If they need to stop, they stop the whole medication instead of just one offended medication. But as soon as they come back to us, we would be able to help them out with the correct prescription. So combined medication is good in overall, but they need to know about what they have to do about it.
So, patient education and counseling along with the medication.
Definitely.
Do
Yes.
you can we counsel our patients? Supposing I'm using dapagliflozin along with sitagliptin with other drugs, would I be scientifically correct if I told my patient that, sir, we are trying to manage your glucose and we are also trying to prevent disease, like maybe kidney disease, heart disease. So please view this as a preventive pill, as a promotive pill, rather than just as a uh, palliative pill. Would I be scientifically correct? And how do you counsel your patients to continue such medication?
Yes, sir. Definitely, we are scientific correct because our ADA guidelines focuses on not only about the hyperglycemia. Now we are targeting cardiovascular risk, renal risk, and also obesity, which is a upcoming high prevalent disease. So, if the diabetic medical, we have to choose according to the patient. If they are at risk of cardiovascular disease, we can either choose GLP-1 agonist and dapagliflozin, and for the renal patients, we can choose this. We have to just explain that we are not only treating your disease and also trying to prevent further cardiometabolic complications or renal complications. So as long as they are advised about it, and we should carry on with this combined pills. We've got a lot of scientific evidence to back up these treatment.
Thank you, ma'am, so much. I am reminded of some couplets from the Thirukural, which is
Okay.
one of the classic Tamil literature epics, where
Yeah.
Sir Thiru, he speaks about the importance of the physician, that the physician has to take a good history, he has to analyze the cause of disease, and then he also has to not only cure but also prevent disease. So, thank you, madam, for putting that our traditional Indian epic into modern context.
Thank you very much, sir. It's really nice having a discussion with you, with your vast experience discussing about an important topic. I'm really grateful for that, sir.
Ma'am, there is just one last question from the audience, and that is again based on the Thirukural. So there is a quadruple of Thirukural.
Okay.
What Thiru said was that four aspects have to be equally strong to get
Yeah,
good therapeutic outcomes. He said the physician has to be strong. Like all the people listening to us, they are good doctors. They do their best.
sure.
The physician has to be strong. The patient has to be educated. The patient should know
Yeah,
about what he or she has to do. The attendant, Thirukural uses the word attendant, but we can use it to mean caregiver at home or maybe diabetes nurse. That
yeah,
has to be that person has to be effective and educated. And the fourth is
yeah.
the drug has to be of good quality. So all four have
Yes,
to be equally strong, only then we will get good outcomes. So ma'am, based upon this quadruple of Thirukural, what do you feel are the needs in India today, and how can all of us together, as more than 1,000 people listening to you right now, how can all of us as Indian physicians strengthen this knowledge from our traditional epics, so that we can strengthen our fellow citizens?
yes, sir. So actually, for doctors, the update on the scientific evidence is more important. And when we attend conference, like we should have active discussions, what we have learned and how do we practice with the current ongoing situation. So the update is more important for the doctors. And if we talk about patient, they have to take a lot of responsibility. I think when they know that this is going to be important to manage their condition, the self-awareness has to come, because whatever we say, and if they don't follow, it's not going to happen. And only when they realize that this is going to be like troublesome if they don't do that, then the self awareness causes motivation and the compliance increases. When we talk about the carer, they have to be like, we should have enough carer. Previously, there were a lot of joint families, now nuclear families, and that is another thing that we need to think about. How do we get carers for the people, old age people in the nuclear families? So probably the government should help um, to support these kind of families. Because why I'm saying is, I know NHS like a lot more supportive for the people with disabilities or any problem. They've got a lot of homes. Um, the, so the government should more concentrate on giving the carers to address these people, and medication has to be available to all economic status of the people, um, for them to access it. So definitely, like all four. more than that we can talk about regarding all these four to put together will definitely improve the outcome of the comorbid condition.
I would like to thank you, madam. In the past half an hour or so, you have put all these four aspects into practice for us. You have shared so much of new information with us in such a listener friendly manner. It was a pleasure listening to you. Secondly,
Thank
even though even though your topic was not diabetes education, the way you have taught us, madam, the way you have shared your information with us, that is the way we should be speaking with our patients and their caregivers. So we have learned how to educate our patients. And of course, you have
definitely, sir.
spoken about, yes,
Yeah,
madam,
I
please.
just want to take this opportunity to tell you one thing because I was managing the patient couple of days ago who has got come for treatment for sickness of cancer treatment, and her sugars were high. She is coming from long distance. She cannot stay longer because I work in Adyar Cancer Institute where I get people from many parts of the country, which is a trust hospital. So this lady is from a low resource setting. So giving insulin become more challenging. So I got the educator. We gave a sample to begin with the insulin injection. We taught her how to administer. She comes back again with the same glucose levels, like around 400. I was completely shocked. We've given like adequate doses. What has been happening? So what happened is like she couldn't administer herself, and she brought her daughter-in-law to do it at home. It looks like just the needle is going in, not the medicine.
Uh-huh.
We figured it out later. And despite continuing to teach, they're not becoming familiar with the insulin administration. They're still struggling, not giving it properly. So we had to take a lot of time for her to make her to take injections. So that is what happening more in the, especially in the low resource setting group.
So thank you, ma'am, for sharing this. And
Thank you.
by listening to you, actually, we all are energized, actually, all physicians of the country. Our theme is 4D, detailed discussion on Indian diabetes and discussion and dialogue. And that is what we have achieved today. And I'm sure we'll go back to our clinics tomorrow, more energized, more enthusiastic, and we are going to work even harder to make India the diabetes care capital of the world. Thank you so much, madam, for being with us. Jai Hind, everybody.
Thank you very much, sir. It's nice to join you today regarding this topic.